We are going to discuss today muscles attaching scapula with the humerus. In previous video, I discussed that there are about 17 muscles which are attached to the scapula, and it is very much difficult to memorize them, but I have categorized them to memorize. It will be easy for you to memorize, and then look at these muscles that we have made four categories of this. Muscles attaching scapula with the axial skeleton. There are 7 muscles. Muscles attaching scapula with the humerus. Again, 7 muscles. So these are the 14 muscles. Remaining 3 muscles, 2 muscles, they are attaching scapula with the forearm bones, and one muscle attaching scapula with the hyoid bone. So we have 17 muscles here. In previous video, I discussed that muscles attaching scapula with the axial skeleton. We have seen that there are about 7 muscles which are attaching scapula with the axial skeleton. 2 are attaching scapula with the axial skeleton anteriorly to the front of the chest. These are the muscles of the pectoral region. One is pectoralis minor, another is serratus anterior. I'll upload inshallah video of muscles of the pectoral region, and you'll see that these muscles will be discussed. These 2 muscles which are attaching scapula with the axial skeleton anteriorly, pectoralis minor, serratus anterior, will be discussed in that video. Then we have 5 muscles which are attaching scapula with the axial skeleton posteriorly. These are the trapezius, latissimus dorsi, levator scapulae, rhomboides minor, and rhomboides major. We have already discussed in the previous video scapular muscles part 1. Now we are discussing the muscles attaching scapula with the humerus. These are 7 muscles attaching scapula with the humerus, just like the muscles attaching scapula with the axial skeleton 7. These are 7. Just like we categorize them, muscles attaching scapula with the axial skeleton 5 and 2, 5 posteriorly, 2 anteriorly. Like here, we categorize these muscles which are attaching scapula with the humerus, again 5 and 2. 5 muscles, they are attaching scapula with the upper end of the humerus, and 2 muscles, they are attaching scapula with the shaft of the humerus. So we will discuss one by one. Muscles which are attaching scapula with the upper end of the humerus, these are short muscles, and these short muscles which are attaching scapula with the upper end of the humerus, mind it that they are arising from the 3 fossa of the scapula: supraspinous fossa, infraspinous fossa, subscapular fossa, and lateral border of the scapula. 2 muscles, these are rounded muscles which are attached to the lateral border of the scapula. They are called as teres. The word teres means rounded. One is larger, another is smaller. So larger one is called as major, smaller one is called as minor. So we have 5 muscles here: subscapularis, supraspinatus, infraspinatus, teres minor, and teres major. Now we are going to discuss one by one. Look at this subscapularis muscle. This subscapularis muscle, as its name shows, that this muscle arises from the subscapular fossa. The anterior surface, I discussed in a video of scapula, the scapula has 2 surfaces, anterior and posterior surface. And both surfaces, they form fossa. But the thing is that on the posterior surface, we have interruption of the spine. So spine, because of the spine, on the posterior surface, we have 2 fossa: above spine, that is supraspinous fossa; below spine, that is infraspinous fossa. But anterior surface is smooth, concave, and some ridges are present here. And this anterior surface is called as subscapular fossa. So the muscle that arises from this anterior surface is called as subscapularis muscle. This muscle which arises from the subscapular fossa and goes laterally to be inserted over the anterior surface of the upper end of the humerus. I already told you in previous video that at the anterior surface of upper end of humerus, we have two important structures. One is lesser tubercle, a smaller tubercle. We have another greater tubercle, but it is facing laterally. The smaller tubercle is facing anteriorly. This is called as lesser tubercle. Another is bicipital groove. But you see that this bicipital groove, because it is actually little bit depression. So two everted edges, you can see this one and this one. And when you compare them, this one is lateral, this one is medial. Two everted edges and one depression, this is floor. These two everted edges are called as lips of the bicipital groove. This groove has another name, intertubercular sulcus, because this sulcus or groove means slight light depression. This is light depression, slight depression, shallow depression. So it is called as groove as well as sulcus, both names. Intertuberculous groove or sulcus. Intertubercular means between two tubercles, greater and lesser tubercle. Our muscle of the arm is passing through this. This is called as the bicep. So this is also called as bicipital groove. So you see that in front of the upper end of the humerus, anterior to the upper end of the humerus, we have two important structures, lesser tubercle and bicipital groove. In bicipital groove, we have three parts. Two everted edges are lips. This is lateral lip, this is medial lip, and one depression, that is floor. Floor of the bicipital groove, lateral lip of the bicipital groove, medial lip of the bicipital groove, and then we have this lesser tubercle. So four structures means that four muscles, they are attached over here. Four muscles. And mind it, that this is a point, that whatever muscles which are attached to the anterior to the upper end of the humerus, they all are medial rotators of the arm at shoulder joint. They cause medial rotation of the arm at the shoulder joint. So one of those muscles is the subscapularis muscle, which arises from the subscapular fossa of the scapula and it goes laterally, and it is inserted over this lesser tubercle. Lesser tubercle or lesser tuberosity, whatever you say, it is same. So it is inserted over the lesser tubercle of the humerus. Okay. This muscle, because it is a subscapular muscle, so it is supplied by upper and lower subscapular nerves. The root value is C5, C6, C7. Major contribution is from C6. Okay. Mind it that whenever we discuss about any muscle, we have to see its origin, its insertion. And whenever we talk about the attachment means both origin and insertion. Or separately, you say origin and insertion, and then nerve supply, and then actions of this muscle. So we have seen its origin from subscapular fossa, its insertion over the lesser tuberosity or lesser tubercle of the humerus. It is nerve supply because it is subscapular. So we have subscapular nerve, but we have two subscapular nerves, upper and lower subscapular nerves. They are arising from the brachial plexus. We will discuss in the video regarding the brachial plexus, and then its actions. You know, I told you that whatever the muscles which are attached to the anterior to the upper end of the humerus, they are medial rotators. So this muscle is attached to the upper end of the humerus anteriorly. It is a medial rotator. This muscle causes medial rotation of the humerus at shoulder joint, or you can say medial rotation of the arm. Importantly, it is a multipinnate muscle. Why it is shown that it is a multipinnate muscle? Because multipinnate muscles, they are strong in action. They are slow in action, but they have strong action, just like we will see another muscle, inshallah, in this video. So now see this. arising from the subscapular fossa, inserted over the lesser tuberosity of the humerus, means in front of the upper end of the humerus, supplied by the subscapular nerve. We have two subscapular nerves, upper and lower subscapular nerve. And the action, it is because it is attached to the anterior to the upper end of the humerus, it is medial rotator of the arm at the shoulder joint. And more important point is a multipinate muscle. Now, next muscle is, one more thing is that regarding the subscapularis muscle, these muscles which we are going to discuss, these muscles which are attaching scapula with the upper end of the humerus, they all are short muscles. And out of these 5 muscles, only one muscle which is not close to the capsule of the shoulder joint. All these 4 muscles, subscapularis, infraspinatus, supraspinatus, teres minor, they all 4 are close to the capsule of the shoulder joint. So they are actually called as the stabilizers of the shoulder joint, and they are forming what is named as the rotator cuff. These 4 muscles, subscapularis, supraspinatus, infraspinatus, and teres minor, they are forming rotator cuff, and they stabilize because they are very much close to the shoulder joint. How they stabilize, we will discuss later on. So they are called as rotator cuff muscles, and they stabilize the shoulder joint. Teres major is not close to the shoulder joint. How? We will see later on when we will discuss teres major. Now, again, you can see subscapular fossa, it is arising from the subscapular fossa, anterior surface. Obviously, it is anterior surface. And lesser tubercle of the humerus, medially rotates and adducts. Another very important action, that this muscle medially rotate and adduct, because you can see if the humerus is away from the midline, it is abduction. This contracts along with other muscle, not only this muscle, this is a short muscle, but it causes little bit, it contribute in adduction of the arm at the shoulder joint. And then it keeps head of humerus in its place close to the glenoid fossa, because head of the humerus, it joins glenoid fossa to form the shoulder joint. And these 4 muscles, I told you, rotator cuff muscles, they are especially because they have the function of stabilizing the shoulder joint. They are forming the rotator cuff. So they keeps head of the humerus in its position, in its place, that it is not to be displaced. Okay. And innervation means nerve supply. It is upper and lower subscapular nerve. You can see here again this greenish color, subscapular, arising from the subscapular fossa and inserted at the lesser tubercle. Another muscle which is called as supraspinatus muscle. I told you that we have 2 surfaces of scapula. Anteriorly, we have a smooth surface, no interruption, but posterior surface having interruption by this process of the scapula. This is called as a spine of the scapula. So both surfaces, they are forming the fossa. Anterior surface has no interruption, smooth single surface. So it is forming single fossa, that is called as the subscapular fossa, from where subscapular muscle is arising. But the posterior surface, you can see that because posterior surface having the interruption of the spine, so posterior fossa actually is divided, though it is a single, but it has an interruption of this. So this fossa is divided into 2 parts. One fossa is above the spine, so it is called as supraspinous, superior to spine, supraspinous fossa, and another is inferior to this spine. It is called as infraspinous fossa. So the muscles which are arising from these 2 fossa, They are named according to name of that fossa. So from the supraspinous fossa, muscle arising is called as supraspinatus muscle. From the infraspinous fossa, muscle is arising called as the infraspinatus muscle. Okay, so here we are discussing supraspinatus muscle. This muscle originates from the supraspinous fossa. When you write down fossa spinous, when you write down muscle spinatus, don't be confused with that. So it is arising from the supraspinatus fossa, supraspinatus muscle arising from the supraspinous fossa, and it is inserted, it passes superior to the shoulder joint. You can see here above the shoulder joint. Then it is inserted over the greater tubercle. I told you that whatever these short four muscles which are forming the rotator cuff muscles, subscapularis, supraspinatus, infraspinatus, and teres minor, they all are attached to the tubercles of the humerus, lesser or greater. On the lesser tubercles, we have only insertion of subscapularis muscle. On the greater tubercle, we have insertion of all remaining three muscles, supraspinatus, infraspinatus, and teres minor. So we have three impressions here. One is upper impression at the greater tubercle. One is lower impression at the greater tubercle. And one is in between these two, the middle impression. So we say upper impression, middle impression, lower impression. These all three impressions, they are lying on the greater tubercle of the humerus. So this supraspinatus muscle is inserted, it arises from the supraspinous fossa, and it is inserted over the upper impression of the greater tubercle. Now see that this muscle, because it is lying in the supraspinous fossa, and supraspinous fossa, it is lying between the spine of the scapula and superior border of the scapula. At the superior border of the scapula, we have suprascapular notch. I have discussed this in my video on scapula, suprascapular notch. From the suprascapular notch, nerve passes. Obviously, that nerve has to be called as suprascapular nerve. Suprascapular nerve. Now, this nerve which passes through suprascapular notch, it is coming to lie in the supraspinous fossa. And in the supraspinous fossa, we have the supraspinatus muscle. So this nerve is supplying the supraspinatus muscle. So you can say that supraspinatus muscle is supplied by suprascapular nerve. Now see that this muscle arising from the supraspinous fossa and crossing the shoulder joint superiorly, and it is inserted over the upper impression of the greater tubercle. Now, whenever it contracts, it actually causing the humerus moving away from the body, away from the median plane. So whatever the structure moving away from the median plane is, we call that movement abduction. So here we have the abduction. Okay, so this muscle, it actually doesn't cause whole abduction. It actually initiate the abduction. That it is how that it is a part of the rotator cuff muscle. We have seen subscapularis, supraspinatus, infraspinatus, and teres minor. These all four are the rotator cuff muscles. Rotator cuff muscles, they stabilize the shoulder joint, especially in three directions. Anteriorly, we have the subscapularis. Superiorly, we have the supraspinatus, and posteriorly, we have two remaining muscles, infraspinatus and teres minor. They stabilize. They keep head of humerus in its place, in its position. But at same time, individually, one muscle can act, can move humerus. Others, what they do, other rotator cuff muscles, suppose here we are uh, uh, discussing about the supraspinatus muscle, that it initiates abduction. It initiates. At same time, other three muscles, subscapularis, infraspinatus, and teres minor, at same time, they hold head of humerus tightly close to the glenoid fossa. They stabilize the shoulder joint. So these three muscles stabilize shoulder joint, subscapularis, infraspinatus, and teres minor. At same time, supraspinatus causes abduction. It starts abduction. Okay. Now it starts. Some books say 15 degrees, some books say up to 30 degrees. There is a variation. So it causes abduction up to 15 or 30 degrees. Then after that, what happens? We are going to discuss later on. But see here, what is the attachment of the supraspinatus, and what is nerve supply, and what are the actions we have seen here. Stabilizing of the shoulder joints and initiation of the abduction. Now, next muscle is, this is also, you can see supraspinatus muscle. You can see this. This is the spine. It arises above the spine from the supraspinous fossa, and it is inserted over the superior surface or superior tubercle or upper tubercle, upper impression, sorry, superior impression or upper impression of the greater tubercle of the humerus. It causes abduction, and it is, you can see the superior support of the glenohumeral joint. Shoulder joint is also called as glenohumeral because it is actually between glenoid fossa and the head of the humerus. Now moving further, you can see that this is the greenish color supraspinatus muscle coming from here, inserted over the upper impression of the greater tubercle. Now, whenever it contracts, what it causes actually, it moves humerus away from the body, away from the median plane. So it causes abduction. Actually, it initiates abduction. Okay. Now, another muscle which is arising from the posterior surface below the spine of the scapula. So below the spine of the scapula, the fossa is called as infraspinous fossa. So the muscle arising is called as infraspinatus muscle. Infraspinatus arising from the infraspinous fossa below the spine of the scapula, and it is inserted over the greater tubercle, but middle impression. I told you we have three impressions. It is superior impression. At the superior impression, we have the supraspinatus, and at the middle impression is the infraspinatus muscle. Okay. Now see that what is the nerve supply of this infraspinatus muscle? We have seen that the nerve supply of the supraspinatus is suprascapular nerve. The suprascapular nerve passes through a notch on the superior border of the scapula that is called as the suprascapular notch. This nerve doesn't stop here in the supraspinous fossa. After supplying it, it supplies the supraspinatus muscle here. Then it passes through infrascapular notch. You can see, I may show you. This is the infrascapular notch. You can see this notch, which is between the spine of the scapula and the glenoid fossa. You can understand this in my video on the scapula. Between the spine of the scapula and the glenoid fossa, we have another notch because it is now inferior to the suprascapular notch. So it is called as infrascapular notch, or especially this notch is lying between the spine of the scapula and the glenoid fossa. This is called as spinoglenoid notch. From here, this suprascapular nerve that lies in the suprascapular fossa, after passing through suprascapular notch, then it passes through the infrascapular notch and comes to lie in the infraspinous fossa. And in the infraspinous fossa, we have this muscle that is the infraspinatus muscle. So this nerve is also supplying the infraspinatus muscle. So you can say that both supraspinatus and infraspinatus, they both are supplied by suprascapular nerve. This muscle is inserted over the middle impression at the greater tubercle of the humerus. Superior impression, at the superior impression, we have the attachment of the supraspinatus. At the middle impression, we have the attachment of the infraspinatus. Now look at the action of this muscle. What it does actually. We discussed that whatever the muscles which are attached to anterior surface of upper end of the humerus, they all are the medial rotators. So go opposite to it. Just opposite it. The muscles which are attached to the posterior surface of the upper end of the humerus, they will be obviously lateral rotators. Muscles attached to the anterior to the upper end of the humerus, they are medial rotators. So the muscles attached to posterior to the upper end of the humerus, they all are the lateral rotators. So this muscle is attached to posterior surface of the upper end of the humerus at the middle impression of the greater tubercle, posterior surface of the upper end of the humerus. This would be obviously the lateral rotator of the arm and shoulder joint. At same time, this muscle is also stabilizing. Whenever you talk about all these four rotator cuff muscles, whenever you discuss actions of these rotator cuff muscles individually, then just do not forget to mention their common action, that they stabilize the shoulder joint. Okay, so its individual action is lateral rotation of the arm at the shoulder joint, but it is also stabilizing the shoulder joint. Now, another, and one more thing is that it is stabilizing shoulder joint, it is lateral rotator, it provides posterior support to the shoulder joint. Shoulder joint, you know, it is most mobile joint of the body. And we know that mobility is inversely proportional to the stability regarding the joints. The joint, if it is more mobile, it is less stable. If it is more stable, it is less mobile. This is most mobile joint of the body. It is less stable. So it is said to be the commonly displaced joint of the body. So it needs many supports. So this muscle is providing posterior support to the shoulder joint as well. This is infraspinatus. Yeah, now you can see individually arising from the infraspinous fossa, and it inserted over the lesser or greater tubercle middle impression. Okay, so it is lateral rotator. It is stabilizing the shoulder joint. It is posterior support to the shoulder joint. Moving more, you can see this is again infraspinatus. Its attachment is origin, its insertion, and you can easily, I told you, whenever you talk about the action of a muscles, generally common sense, using your common sense, generally you keep in mind that see the relation of the muscle with the joint, see the direction of the fibers of the muscles. See the attachment. This is arising from the infraspinatus fossa, inserted over the greater tubercle. Direction of fibers is horizontally towards from the scapula towards the humerus. And so this is the direction of pull of the muscle. So whenever it contracts, what it does actually, it contracts, it moves the scapula laterally. So we have the lateral rotation of the arm at the shoulder joint. Okay. Another muscle which is part of the rotator cuff, fourth muscle, teres minor. Now, three muscles we have already discussed, they are arising from the fossa, three fossa. Now these remaining two muscles, they are arising from the lateral border of the scapula. These both muscles, they are rounded, so they are called as teres. Word teres means rounded. And one is larger one, another is smaller one. So one is obviously the larger one is called as teres major, the smaller one is called as teres minor. But which is above and which is below, just keep in mind that larger one says that I can, I am large, so I can support you. I put you superior to me. I put you superior to me, that you are to be supported inferiorly. So I keep myself, my major says that I keep myself inferiorly. So see that whenever you talk about the attachment of these two muscles on the lateral border of the scapula, just look at this, the teres minor being short muscle, it has to be above, and teres major, it has to be below. So teres minor is arising from the upper part of the lateral border of the scapula, and it is inserted over the greater tubercle, now remaining the inferior impression, lower impression. We have three impressions: superior impression for the attachment of the supraspinatus, middle impression for the attachment of the infraspinatus, and the lower impression for the attachment of the teres minor. So teres minor is attached over the lower impression of the greater tubercle, arising from the upper part of the lateral border of the scapula. There is a gap in this attachment of the teres minor over upper part of the lateral border of the scapula. There is a gap, and from this gap, a very important artery that is called as a circumflex scapular artery. It is called circumflex because actually it is lying anterior to the scapula. It encircles the lateral border of the scapula and comes to lie in the infraspinous fossa. So it encircles actually the lateral border. It is called a circumflex. Circumflex means encircling. So this circumflex scapular artery, it is passing through this gap that is lying in the attachment of the teres minor over the lateral border of the scapula. Okay, now this nerve is supplied by this muscle is supplied by axillary nerve. This muscle is supplied by axillary nerve. Looking at this, now don't look at the material, just look at, you understand how that, you see that this muscle going from the lateral border of the scapula to the greater tubercle means that lower impression means that it is attached to the upper end of the humerus posteriorly. And I told you whatever the muscles which are attached to the upper end of the humerus posteriorly, they all are the lateral rotators. So this is the lateral rotators of the arm at the shoulder joint, and somehow because it is lower down, it actually pulls this humerus towards the midline. So it causes adduction at the shoulder as well. It assists actually. It assists the adduction of the arm at the shoulder. And more importantly, the important one is that it is lateral rotator. Infraspinatus and teres minor both. Now look at these both. Suppose these both are present here, teres minor and infraspinatus. I may show you. Yes, now you can see here. Teres minor, this is infraspinatus and this is teres minor. They both are present posteriorly. So they are attached to the posterior to the upper end of the humerus. They both are lateral rotators at the shoulder joint. They both carry humerus towards the midline. They are the adductors somehow, not major adductors, but somehow they cause adduction. They are present posteriorly. They contract. They pulse scapula even more posteriorly. This is the extension at the shoulder joint. Somehow they are the extensor at the shoulder joint. They, being a part of the rotator cuff, they stabilize the shoulder joint, and they are present posteriorly. So they support the shoulder joint posteriorly. Okay, or you can say they stabilize shoulder joint posteriorly. So this is the action of the teres minor muscle. Now looking at another muscle, that is rounded muscle lying down, lower down, it is teres major muscle, which is attached, which actually having origin from the lower part of the lateral border of the scapula. You can see here, lower part of the lateral border of the scapula. It goes laterally. It goes laterally and little bit anteriorly. Though it is attached to the upper end of the humerus, but it is going anteriorly, it is attached to the upper end of the humerus anteriorly. Now you can see here from the front. This is back view, attached to the lateral border of the scapula and upper end of the humerus anteriorly. It is going anteriorly. Here you can see. This is the front view. It is attached to the lateral border of the scapula, going to be attached to the upper end of the humerus anteriorly. So we have two structure upper end of the humerus, lesser tubercle, which is already occupied by subscapularis muscle. Remaining is the bicipital groove. We have three parts: lateral lip of the bicipital groove, medial lip of the bicipital groove, and floor of the bicipital groove. This teres major muscle is attached to the medial lip of the bicipital groove. Now you see that this muscle, which is, I told you, see the direction of the muscle. The fibers going from scapula towards the anterior part of the humerus at upper end. Anterior part of the upper end of the humerus. So whenever it contracts, it pulls humerus posteriorly. Somehow it is the extensor of the arm at the shoulder joint. It pulls humerus towards the midline. It is an adductor of the shoulder, adductor of the arm at the shoulder joint. The third thing, it is extensor, it is adductor. The third thing, that it is attached to the upper end of the humerus anteriorly. So whatever the muscles which are attached to the upper end of the humerus anteriorly, they all are the medial rotators. So this is the medial rotator of the arm. Okay. You can see that it extends arm, it assists in adduction and medial rotation of the arm at the shoulder joint. This muscle is supplied by lower subscapular nerve. Why it is supplied by the lower subscapular nerve? You just see that it has the insertion over the lateral lip of the bicipital groove. Above the lateral lip of the bicipital groove is continuation of the lesser tubercle of the humerus. On the lesser tubercle, we have the attachment insertion of the subscapular muscle. And subscapular muscle is supplied by two nerves. Upper subscapular nerve, which supplies the upper portion of this muscle. Lower subscapular nerve, supplying the lower portion of the subscapular muscle. So lower portion of the subscapular muscle is very much close to the teres major. And teres major is in line on the insertion, it is in line with the subscapularis. So the lower portion of the subscapularis is supplied by lower subscapular nerve. So lower subscapular nerve is, because it is in line with the teres major, is also supplying the teres major muscle. So teres major is supplied by the lower subscapular nerve. Okay. Now you can see here the infraspinatus, teres minor, and teres major muscles. These three muscles, rotator cuff muscles. The fourth one is the subscapular muscle. You have seen. Now how the rotator cuff is formed. You see here. Looking at this palm of this fingers of the hand, 4 fingers. One finger it is on the lesser tubercle, 3 fingers on the greater tubercle. So you can see that thumb is on the lesser tubercle, it represents subscapularis muscle. Index finger representing supraspinatus muscle. Middle finger representing infraspinatus muscle. and ring finger is representing teres minor muscle. 4 muscles, they are attached over here, tubercles. The muscles which are attached to these tubercles, greater or lesser, they are close to the shoulder joint capsule, so they stabilize. Because you see that whenever these muscles, they are going towards their insertion, muscles at their origin are at their insertion, they are fibrous. So fibrous band, I told you, fibrous band that attaches muscle with the bone, it is called as the tendon. So at the initiation, at the origin, muscle has tendon. At the insertion, muscle has the tendon. And in between two tendon, origin and insertion tendon, we have a muscular fibers. So we have a tendons of these muscles, they are attached over here. The part of the muscles which is attached to the bone is tendon. Muscle fibers, mostly they do not attach directly to the bone. These are the tendons. So we see here the tendinous fibers, they are attached over the lesser tubercle, subscapularis, and 3 muscles, supraspinatus, infraspinatus, teres minor. These 3 tendons, they are attached over here, greater tubercle. The tendinous fibers, just like the fibrous band, so we have the capsule of the shoulder joint, it is also fibrous. They both fuse, the tendons of these 4 muscles and the capsule, they fuse with each other. So just like by fusing with the capsule, they are supporting the capsule of the shoulder joint. They are actually strengthening the capsule of the shoulder joint. And whenever the capsule is strengthened, the shoulder joint is stabilized. Okay. So because of that, these 4 muscles are called as stabilizing muscles of the shoulder joint. Then you can see that on the bicipital groove, we have 3 portions: lateral lip, medial lip, and floor. On the lateral lip, we have a major muscle attached, is called as major. That muscle is from the pectoral region, so it is called as pectoralis major. On the medial lip, we have a major muscle from the scapular region, that is the teres major, inserted over here. On both lips, we have major muscles. And in the floor, we have a muscle of the posterior dorsal aspect or scapular region that attaches the scapula with the axial skeleton. This is called as the latissimus dorsi, means L. L in the floor, major on the lateral lip, major on the medial lip. So it is called a lady between 2 majors. You can remember the names of these muscles: lady, L between 2 majors, L in the floor, floor between 2 lips. So lady between 2 majors, L, latissimus dorsi in the floor of the bicipital groove attached. On the medial lip, we have the teres major is attached. You can see here on the lateral lip, we have the pectoralis major is attached here. So rotator cuff muscles, you can see here. From the back, you can see we have 3 muscles: infraspinatus. This is supraspinatus here. This is infraspinatus. This is teres minor. 2 muscles from posterior aspect, 1 from above, 1 from anterior aspect. You can see this is the subscapularis muscle. Okay. So they all 4 rotator cuff muscles, they are supporting the shoulder joint from 3 directions: superiorly supraspinatus, anteriorly subscapularis, posteriorly infraspinatus, and teres minor. Okay. You can see here also. This is the subscapularis in front. From above, supraspinatus. This is on the posterior aspect, we have the infraspinatus, and then below that we have the teres minor. This is best view. You can understand here all 4 rotator cuff muscles. Though this is not purely rotator cuff, because you can see that subscapularis is a medial rotator because it is attached to the anterior surface of front of the humerus. Anterior surface of the upper end of the humerus. Teres minor and infraspinatus, they are attached to the posterior surface of the upper end of the humerus. They both are lateral rotators. These 3 are rotators: subscapularis, medial rotator; Infraspinatus and teres minor are lateral rotators. But supraspinatus is not rotator. It is the initiator of abduction. This is abductor muscle. So no any pure rotation for all these four muscles because supraspinatus is different. And no any pure cuff. Cuff means that is surrounding the sleeve that is surrounding your wrist. It is cuff. But you see surrounding in all directions. But you can see that subscapular is present anteriorly, supraspinatus superiorly, and infraspinatus teres minor posteriorly. But no any muscle is present inferiorly out of these four muscles. So inferior support is deficient. No pure cuff. But though they are called as rotator cuff muscles, so we can name them as a rotator cuff. See this. Supraspinatus muscle. Now the supraspinatus muscle, when it arises from the supraspinous fossa going laterally just above the shoulder joint, it is lying here below the acromion process of the scapula. This is the acromion process. I told you this is forming the summit of the shoulder. Summit means acro, omos means shoulders. So that's called combination of these two acromion process. It is lying below the acromion process. Now there are chances of friction between the acromion process and the supraspinatus muscle. A space is formed here. This is called a subacromial space. Subacromial space is between acromion process and supraspinatus muscle. Here we have chances of friction between acromion process and supraspinatus muscle. This has to be prevented. So nature has given a bag of synovial fluid. Bag of synovial fluid, which is called as bursa. Bursa is a bag of synovial fluid. Synovial fluid bag, when it lies between acromion process and the supraspinatus tendon. You can see this is the supraspinatus tendon and this is the acromion process. In between these two, we have this bag of synovial fluid. This is called as, because it is lying below the acromion process, it's called in the subacromial space. So it is called subacromial bursa. This actually prevents the friction between the supraspinatus muscle and acromion process, subacromial bursa. So it creates frictionless environment here. Okay. Now, rotator cuff muscle tear. Tear may occur in any muscle of the rotator cuff. Supraspinatus, infraspinatus, teres minor, teres minor and subscapularis. In any muscle. This is in subscapularis, supraspinatus, and from back we have the infraspinatus and teres minor. But especially in the supraspinatus, because that supraspinatus initiates abduction. You are keeping arm away from the median plane and against the gravity, you are pulling the arm up. So there is a pressure over this supraspinatus. Commonly tear occurs in the supraspinatus, but there is tear may occur in any of the rotator cuff muscle. So it creates a problem. It actually weakens the movement that occurs here, weakens the movement. So weakens the movement of that muscle in which the tear occurs. If it is in a supraspinatus, it actually weakens the initiation of the abduction. You might passively initiate the abduction. Passively means supporting your arm to initiate the abduction by opposite hand. Okay. This is the subacromial bursa. Swollen bursa can cause impingement. When there is inflammation of this bursa and it swells, swollen bursa, impingement means there is restrictions of the movements. That the acromion process, bursa and supraspinatus, they fuse with each other. This is impingement, and there is a irritation, there is a pain, and you cannot move the arm. You feel much more pain. This is the impingement of this, and you can see here subacromial impingement. It impinges. It is fused with the acromion process. It fused with the supraspinatus. Okay, you can see this tear. I told you. This tear may occur in any of the rotator cuff muscles, supraspinatus, subscapularis. These are 5 muscles which are attaching scapula with the upper end of the humerus, and remaining 2 muscles which are attaching scapula with the shaft of the humerus. We will end up this video, inshallah, after discussion of these 2 muscles. One muscle that arises from the coracoid process and going to be inserted at the shaft of the humerus. Shaft of the humerus means this muscle is going to the arm. In anatomy, arm, the word used for the arm is brachium. This muscle extends from the coracoid process to the brachium to the arm. So it is called as coracobrachialis muscle. It arises from the tip of the coracoid process. What is the tip of the coracoid process? You see the video of my video of scapula. You will come to know about the tip of the coracoid process, the portion of the pointed portion of the coracoid process. So it arises from the tip of the coracoid process, and it is inserted at the shaft of the humerus on the medial aspect of the mid of the shaft of the humerus. This is the middle of the shaft of the humerus. This muscle is inserted over the medial aspect of the middle of the shaft of the humerus. Shaft of the humerus, medial side. It is exactly in the middle of the shaft of the humerus. So medial side of the middle of the shaft of the humerus, it is inserted over here. This muscle is supplied by, because this muscle is included in the front of the arm, and front of the arm, the nerve for the front of the arm is the musculocutaneous nerve. This nerve has 2 portions. One is muscular, which is for the arm. One is cutaneous, which is for the forearm. We will discuss when we will discuss musculocutaneous nerve. In that video, you'll see how this nerve is arising from the brachial plexus and how it is going to supply. So this is musculocutaneous nerve, the nerve of the front of the arm. It is supplying to this muscle, coracobrachialis muscle. But it has a specialty. It has a specialty that this nerve, it pierces. You can see here. This muscle, this nerve pierces this coracobrachialis. Piercing means that passing through this muscle. From posterior, it is passing through this muscle, comes to lie anterior to this muscle, and now it runs in the front of the arm. But it is passing through, it means that it actually asking for the gate from this muscle. It is asking from this muscle for gate to pass through this. So it has to give bribe to this muscle. Bribe means that it has to supply before that, before passing through this muscle, this musculocutaneous nerve has to supply this coracobrachialis muscle. It gives, first of all, it gives a branch to the coracobrachialis. Then it means that it actually getting permission by supplying this muscle. It is getting permission from this muscle to pass through that. So it supplies this muscle. It gives branch to this muscle. Then it passes through this muscle to comes to lie in front of the arm, and then it runs downwards. So musculocutaneous nerve is supplying this muscle, and it is passing through this muscle. This muscle, you can see that it is going from the coracoid process to the shaft of the humerus. So what would be the action of this muscle? You see, whenever it contracts, it pulls this humerus towards the midline. You can see this arrow towards the midline. So it is causing adduction of the arm at the shoulder joint. It is an adductor. And then it is actually crossing the shoulder joint anteriorly. I told you, see the direction of fibers of the muscle and see the relation of the muscle with the joint where it is causing movement. So whenever it contracts, first of all, it causing the pulling of the humerus towards the midline. It is causing adduction of the arm at the shoulder, and it is crossing shoulder joint anteriorly. It is actually more, whenever it is contracting more than this, then it pulls this humerus in front of the thoracic wall or chest wall. Means that you are taking your arm in front of the chest. This is called as flexion. of the arm at the shoulder joint. So two functions are assigned to this muscle, coracobrachialis, flexion and adduction. Okay. So now you can understand that flexion and adduction at the shoulder joint is caused by coracobrachialis muscle. Another muscle which is attaching scapula with the shaft of the humerus. Now it is called as a deltoid muscle. It is from the bulk of the lateral side of the shoulder joint. This bulk is clinically very much important. We are going to discuss this muscle, which is actually not only arising from the scapula, but is also arising from the clavicle as well. So you can say that it is arising from the shoulder girdle. This is a major muscle of the shoulder girdle because it has a more important action to do. It has multiple actions. It is divided into just like the trapezius. It is that in the trapezius we discussed that we have three types of fibers: upper fibers, middle fibers, lower fibers. So this muscle, because it was horizontal, it has three fibers: upper, middle, lower. This muscle is lying vertical. It has three fibers: anterior, middle, posterior. Anterior fibers, middle fibers, posterior fibers. These three fibers, they have separate origin because it is arising from whole of the shoulder girdle. Anterior fibers, they are arising, shoulder girdle means scapula and the clavicle. So anterior fibers are arising from the clavicle. You can see lateral third of the clavicle. We know lateral third of clavicle having two borders, anterior and posterior fiber borders. So these anterior fibers of the deltoid, they are arising from the anterior border of the lateral third of the clavicle. Middle fibers, they are arising from the acromion process. The acromion process having two borders, medial and lateral border. This muscle is lying laterally, so it is arising from the lateral border of the acromion process. The middle fibers of this muscle. So middle fibers, they are arising from the lateral border of the acromion process. And the posterior fibers, they are arising from the lower lip of the posterior border of the spine of the scapula. Rather, you say posterior border of the spine of the scapula. Posterior fibers, they are arising from the posterior border of the spine of the scapula. Now, again, anterior fibers from the anterior border of the lateral third of clavicle. Posterior fiber from the posterior border of the scapula. Now it is easily to remember. Anterior fibers from the anterior border of the lateral third of the clavicle. Posterior fibers from the posterior border of the spine of the scapula. And middle fibers from the lateral border of the, because exactly they are lateral, so they are arising from the lateral border of the acromion process. And especially is this anterior fibers, they are unipinnate. Posterior are also unipinnate, but the middle fibers, they are multipinnate. Why? Because, and we have already differentiated that unipinnate fibers, they are fast in action, but they're weaker in action. Multipinnate fibers, they are slow in action, but they are strong in action. Why these middle fibers, they need strength? Why they are multipinnate? We are going to discuss. Now, anterior fibers, looking at this deltoid muscle is supplied by, whenever you look at the nerve supply of this muscle, it is supplied by the axillary nerve. Now, looking at this muscle, action of this muscle, anterior fibers, which are more anteriorly, whenever they contract, they cause movement of the humerus anterior to the chest wall. Somehow they flex the arm at the shoulder. They are flexors of the arm at the shoulder, anterior fibers of the deltoid. And one more thing, that not only this, that they are the flexors at the shoulder joint, but they are the medial rotators as well. They are the medial rotator of the arm at the shoulder joint. So they are the flexors and the medial rotator because they are presenting anteriorly. I told you anteriorly presenting. They are related to the upper end of the humerus anteriorly. Posterior fibers, just opposite to the anterior fibers, they cause extension at the shoulder joint, pulling humerus posteriorly, pulling arm posteriorly, and they are presenting posterior to the upper end of the humerus. They are lateral rotators of the arm at the shoulder joint. Anterior fibers, flexor and medial rotator of the arm. Posterior fibers, they are the extensors and the lateral rotator of the arm. Middle fibers. Before going to the middle fibers, this whole muscle is inserted over the lateral aspect of the middle of the shaft of the humerus. Just opposite the attachment of the coracobrachialis muscle. At the middle of the shaft of the humerus, we have two portions: medial portion, lateral portion. Medial portion, we have the insertion of the coracobrachialis. At the lateral portion, we have the attachment of the deltoid muscle. We have here a V-shaped tuberosity because of the attachment of this muscle. That V-shape, because V-shape means it is forming the delta. So the tuberosity is called as the deltoid tuberosity. So the muscle is called as the deltoid muscle. So this muscle is inserted over the deltoid tuberosity, which is present on the lateral aspect of the middle of the shaft of the humerus. Okay. Now looking at that action, anterior fibers, they are the flexors and the lateral medial rotators. Posterior fibers, they are the extensors and the lateral rotators. Middle fibers, they contract, they are multipinate. Why they are multipinate? When they contract, they pulls humerus away from the body, more upwards. Now away from the body means abduction, and it is going more upward. More upward means against the gravity. Now against the gravity, you need a force here. Because you are going against the gravity, you are taking your arm against the gravity, you need a force here. For the force, we need a force. So this force is provided by these multipinate middle fibers of the trapezius. Because of that, they need force, they are multipinate. They are slower in action, but they are strong. So they are strong, so they are carrying arm against the gravity. So these middle fibers, they are the abductors of the arm. But this abduction is from 15 or 30 degrees, because up to 15 or 30 degrees, there is a variation. That initiation is caused by supraspinatus. Abduction is a mechanism. Initiation is caused by the supraspinatus. And then this abduction continues from this 15 or 30 degrees up to 90 degrees. This action is carried out by the middle fibers of the deltoid, which are multipinate. After the 30 degrees, when you carry your arm over the head, this is called as overhead abduction. That overhead abduction is caused by upper and lower fibers of trapezius. And trapezius, in that video I discussed upper and lower fibers of trapezius and lower fibers of serratus anterior muscles. These three fibers, upper fibers of trapezius, lower fibers of trapezius, and lower fibers of serratus anterior, they cause overhead abduction. But up to this, you see middle fibers, they are of the deltoid, they are causing abduction from 15 or 30 degrees to the 90 degrees, up to 90 degrees. It is caused by the middle fibers, multipinate fibers of the deltoid, which are arising from the lateral border of the acromion process. You can see here anterior fibers showing arrow. Anterior fibers, they are the medial rotators and flexors. Posterior fibers, they are the lateral rotators and the extensors. Middle fibers, they are taking this arm up. They are the abductor of the arm at the shoulder joint. Deltoid, sometimes we have a pain here at the deltoid muscle. This is called as deltoid muscle pain. Whenever there is a pain over the tip of the shoulder joint, over the tip of the shoulder, pain is from two reasons. One is that we have the subacromial bursitis, inflammation of the subacromial bursa, and deltoid muscle that radiates to the, but pain which radiates to Subacromial bursitis pain does not radiate. When pain at the tip of the shoulder and it radiates to the arm, this is a deltoid pain. What happens in this? You feel difficulty in moving in abducting the arm. In moving the arm, there is a weakness of the shoulder, and you feel difficulty whenever you lift any object. You have a difficulty because you feel pain. And whenever you're performing pushing, pulling movements, all these felt difficult because of the pain in the deltoid. So this is the deltoid muscle pain at the tip radiating towards the arm, and you will have a difficulty in, you have a weakness of this muscle, you have a difficulty of movement of pulling, pushing, lifting objects because of you feel pain in the deltoid. Okay. Then another clinical importance of this muscle, deltoid muscle, very bulky muscle of this region, that when we make a triangle of this muscle over here, just below the acromion process, 2 fingers below the acromion process, we make an imaginary line here, and at both ends of the imaginary line, we put dot over here, and third dot we put over the insertion of the deltoid, and joining these 3 dots, we make a triangle over here. This is deltoid triangle. Okay, you can see here, imaginary line, and then you see here, and you join these lines, triangle is made, inverted triangle. This is deltoid triangle. It is actually clinically important because this triangle is formed here. It is used for, because it is a bulky muscle. Whatever the bulky muscle, especially in the body, they are used for intramuscular injection. When are you are putting injections in the muscles, you are performing injection. Some drugs are being given through muscles. So bulky muscles are to be used. In the lower limb, we have the gluteal muscles, especially gluteus maximus. In the upper limb, we have the deltoid muscle because it's a bulky muscle. And middle fibers are used because they are multipennate. Multipennate fibers are more thick. We need thickness here. So for the intramuscular injection, deltoid muscle is used, and we make this triangle by imaginary line just 2 fingers below the acromion process. Dots are being put at the ends of this imaginary line. Third dot is at the insertion of the deltoid. Joining these dots, we make an inverted triangle, and inserting injection in this triangle, you are giving the intramuscular injections in the deltoid. Okay. So this is, now these short muscles, one more thing, that these short muscles, they make spaces, axillary spaces. We will discuss later on. In another video, I will discuss axillary spaces, that how they are made and what the structures they are passed through these spaces. Thank you very much for this. Hope you will like and subscribe my channel, and wait for